Welcome to the Parent of Mouth Breathers podcast. Today I'm joined by Dr. Suraj Vatish. Dr. Suraj is an experienced dental surgeon specialising in tongue tie and lip tie releases, particularly in children. He leads the Tongue Tie and Breathing Centre at Happy Kids in Chelsea, London, and he's known as the Tongue Tie Guy on Instagram. Dr. Suraj, thank you so much for joining me. For those discovering you for the first time, can you tell us a bit about your background and the work you do?
Okay, well, firstly, thank you very much, Natasha, for having me. It's such a pleasure to be here to speak to you and your listeners about my experience and how I come into tongue ties. Now, it's a really funny story with me because my background is in oral surgery and implants. And I kind of stumbled across tongue tie because my colleague, Roxalana, who runs the practice here, was telling me about tongue tie treatment. Now, everyone knows that, those of you who know me, know that I actually did some tongue ties with scissors back in Spain when I was doing my oral surgery training. And I swore off the procedure. I was like, I'm never going to do this because the procedure bled a lot. And I never really touched on it again. And then Roxanne asked me to do a course by Dr. Richard Baxter. And then he was the kind of my opening eye into this whole airway world, because we started treating babies, younger children first. And then as I kind of grew in the tongue tie field, I did Dr. Zaghi's course in the States, and my whole eyes then, I'll say, completely opened. Because coming to it from a dental point of view, I feel we see so many effects of the tie, but we're just not educated on what it kind of is. And we should be the first line of defense for a lot of the older children on, wait, this is a tongue tie, this is crowding, this is how we should be treating our patients. But I kind of come at it from a very dental, surgical-based background. Obviously, I love collaborating with other healthcare professionals such as ENTs, myofunctional therapists, speech and language therapists. And that's also kind of pushed us into opening a first multidisciplinary center. So in Happy Kids Tongue Tie and Breathing Center, we have a consultant pediatrician who's also working side by side with me. We have a myofunctional therapist. We have a speech and language therapist. We have osteopaths, and we also have a lactation consultant coming to join us as well.
That's amazing. I actually didn't realize that's what you were creating with the clinic, is this multidisciplinary approach. One of my questions later on in the interview actually is about why that's so important to have people coming at it from all different specialisms. So that's really interesting. A really good segue, I guess, in that you were introduced to this and you sort of started looking into this yourself, and that was sort of very self-directed. So can you talk to me about some of the myths? I just want to share an anecdote really quickly.
Okay.
When I took my son to be assessed by the ENT, and I was concerned around tongue tie and whatnot, they effectively asked him to point his tongue out. That was their official assessment. And because he could extend his tongue outside of his mouth, they decided that he didn't have a tongue tie. That was all they did. And it was only further down the line that I discovered he did actually have tongue tie, and, you know, the person that we took him to used some apparatus to look under it. So what are some of the myths, such things like I was told and other parents are told, if they can point it out, it's not a tongue tie? Is that false?
100%.
Okay.
Actually, we know the funny thing was I was just having a discussion with one of my colleagues because I had a patient come into me and the tongue was almost completely restricted to the tip. You can't get any more restriction than this. And she could extend her tongue out past her lips and almost touch her chin. And then my colleague was like to me, but there's no tongue tie here. And I said, all right. We got her then to try and lift her tongue up, and she had no elevation. The biggest, unfortunately, myth is that if you can poke your tongue out, you don't have a tie. And you can't be further from the truth, because sticking your tongue out actually comes from other muscles, not the actual tongue itself. And what we always look at is we look at the elevation of the tongue. So the best way to test older children and adults is open your mouth as wide as you can. And without closing your jaw, try and elevate your tongue behind your front teeth. Now, if you can get your tongue up there very easily, it's likely that you don't have an obvious tongue tie. Now, another myth that I commonly get is mild versus severe tongue ties. And this is something I always like to touch on, which I believe tongue tie is very binary. It's like almost being pregnant. It's either you're pregnant or you're not. So you're tongue tied or you're not. And restrictions are called, if it's completely tied, we say it's a severe restriction. If it's not very obvious or mild, we say it's a mild restriction, which I don't agree with, because end of the day, the tongue's restricted, whether it's obvious or less obvious. And the way I have been educating practitioners about this is, if I tie both of your feet up, whether I tie them very close or whether I tie them very far away, they're still tied. Yes, you might be able to walk a bit more with one than the other, but a restriction is still a restriction.
That's a really good analogy, actually, a good visual for people to think about, because I was certainly under the impression that tongue ties came, at varying degrees, which I know you're saying they do, but primarily, if a tongue is tied, and there are going to be a lot of downstream effects because it's tied. Okay, so what is a tongue tie? How would you define that?
Great question. So to make it very simple, a tongue tie is anything that stops the tongue from moving freely in the mouth. Now, you've got to think of the tongue as a free moving muscle, and anything that stops that is called a tongue tie, in my opinion. Now, this might vary from health professional to health professional, but in essence, the tongue needs to move freely without use of the lower jaw, back of the neck, or even the lower neck as well. Now, some patients you'll see when they're tongue tied, especially in the older children and adults, they open their jaw and they're using these muscles to elevate their tongue. That's what we call a compensation. Okay. So when we have any restrictions in the mouth, the body tries to auto-correct itself, because the body always wants to optimize movement. And what it does then, it starts recruiting the closest muscles to the tongue, which is floor of the mouth, jaw, back of the neck. And we see this in a lot of our patients with their symptoms, because adults and older children will complain about they've got very tight neck, grinding their teeth, or they've got tight jaws, backache. Dentally, we see this a lot as grounded teeth. And teeth grinding in children and adults is definitely something that's completely overlooked in children. Most people will tell you they'll grow out of it. In adults, you just give them a mouth guard and send on your way.
Mm-hmm. So in terms of, you've mentioned some of the symptoms there, why does it matter so much? Why is tongue tie a problem, and why should we, particularly as parents of young children, be looking at this and taking it seriously?
Okay, so the way I tell my patients is there's three pillars of what I say to physiological health, that these actions we need to survive and thrive. Those are sleeping, breathing, and eating. Now, no one can argue that we don't need to do these three things to survive. We all, I think, agree on that. Now, the difference between surviving and thriving comes down to how these functions are optimized. Now, if you look at these three pillars, all of them have one thing in common, that they use your tongue. Use your tongue to swallow. Your tongue's a switch. It sits on the palate. It allows us to breathe in through our nose. Now, nose breathing is one of the most foundational pillars for health. We breathe in through our mouth. We are already getting 20% less oxygen. We are then impacting how our face and upper jaws form. And we are also in sleep cycles getting less deep or REM sleep. So when parents ask me, well, how does it affect these things? I said, if the tongue's tied, your body then, instead of using this energy for other functions such as growth, etc., focuses on, okay, I need to optimize the swallow. So you use more muscles to swallow than you should. It uses sleep, and then on top of that, the sleep's compromised, because as soon as we relax, all these muscle groups drop, and then we start breathing through our mouth. That means our sleep suffers. And then lastly, if we're mouth breathing, our breathing suffers.
Yeah.
And instead of your child using all the energy to keep the lights on, which no one's saying we're not going to survive, but your children will find it very hard to thrive.
And that's so interesting. So much of what you've said there applies to both my sons, unfortunately. But that idea that this connects to airway health as a whole, and that it is a very important component, even though it's difficult for me to hear, because I know that there's still a long way to go for my son in particular, it's also encouraging to know that actually it is something that needs to be looked at and to be taken seriously. And I'm not wasting my time by doing that. I've been sort of on Instagram for just over a month now, really trying to open up this conversation. And tongue tie has to be the question that I get the most from other parents, wanting to know what type of results I had after having my son's procedure done, but also wanting to learn about the connection between tongue tie and airway health as a whole. And for a lot of us, I'm coming from a background where I have to rely upon the NHS. And we are being told that a tongue tie isn't something to worry about from ENT surgeons on a daily basis. And so it's really great for you to frame that in such a way to sort of educate people on how important it is and how that does actually affect airway health as a whole. It's very confusing for us parents out here because we're just, we're being told so many things, and, we're learning a lot of our stuff from people like yourself through Instagram. And unfortunately, the medical system needs to catch up a little bit, particularly where the NHS is concerned. So you've explained sort of the link with tongue ties and airway health. So what are some of the consequences, if it's missed in young children? How does that look as children get older and then turn into adults? What are some of the downstream effects of that?
Okay, so we go back to the 3 pillars of health there, and we start to see effects on all kind of different organisms of the system. So one interesting fact is our tongues are actually linked up to our feet with a layer called fascia. And when this fascial chain is tight, now people are told we grow out of it, the body actually grows around it. Now, the first kind of signs you see is issues with speech. So you might see that, okay, if you're not very, let's put sleep to aside first, because that's one other thing parents kind of do come to me for. But the main thing they come to me if it's been missed as a child is, my child's not speaking well yet. Or we've got issues with pronunciations, R's, L's, S's, T's, BPMs, and W's. And one of the common misconceptions also is that tongue ties don't affect speech. And going back to those tied shoelace analogy, your brain will send signals to your tongue when it wants it to move. Now, if that muscle's not moving well, or you're requiring more energy to use it, is speaking going to be easier or harder? It's going to be harder for these children. And once we accept the fact that, yes, sometimes we are doing tongue releases and we're not seeing immediate improvements in speech. And I work with a lot of speech and language therapists, and we work together to get these children moving their tongue better. Our main aim is to make it easier. So the first thing I'll say we see is kind of speech issues. We then, after seeing these patients discuss a bit more, we kind of sometimes see they're poor sleepers. A lot of patients with tongue tie kind of wake up very frequently throughout the night. Unfortunately, some of them even suffer from bedwetting, which is really difficult in the older children. And you'll constantly see these children with kind of dark circles under their eyes. We then also can look at talking before we get to the mouth, we look at the digestion side. Very, very picky eating, because when you've got a tongue tie, sometimes your gag reflex is very prematurely stimulated, and these children want to avoid certain textures of food. So either they would avoid very hard textures, or they keep very soft, or sometimes they're very worried about swallowing. So parents will come to me and saying, he's just a vacuum. He just goes in and gulps everything down. Now, this unfortunately can be paired with a condition called aerophagia, or swallowing of air. And what that does is, when we have a tongue tie, we end up using our jaws, back of the neck to do swallowing. So in infants, we see this a lot, contributes to reflux. They swallow a lot of air that goes into the digestive tract. This then causes bloating, gassiness. In my adult patients, sometimes IBS diagnosis, which is something very personal to myself. I've close family members suffering from it this way. And also in children, the nutrition gets affected. Now, we then look at the mouth and oral development. Now, these tongue-tie patients generally present with a lot of crowding because the tongue is not there to support the upper face and jaw of the palate. We'll see very narrow faces. From another dental side, if the tongue is quite restricted, the self-cleaning ability of the tongue, which once we eat food, the tongue likes to clean the mouth around. We see decay, gum disease, or more predisposition for that as well. Then we see mouth breathing, because low tongue posture will not allow us to breathe through our nose. We end up breathing in through our mouths, impacting sleep even more, focus, oxygen in the body as well, ultimately leading to more stress on the organism.
One of the things that I noticed with my son is he bites his lips a lot, his inner cheeks, or will bite his tongue a lot whilst he's eating.
Yeah.
And he gets really, really frustrated. And when we went to see an airway dentist actually in London last year, she put some composites on the 2 back teeth just to make some more room in his mouth. Now, we knew they weren't sort of a permanent solution anyway, but in the time that he did have them on, in the short time that he had them on, that was the thing that we noticed, that he wasn't biting his cheeks or his tongue whilst he was eating.
Yeah.
He's got all of, or many of the things that you've laid out there, the crowding of the teeth, and there's clearly not enough room for his tongue in his mouth, you know. So that's definitely something that we noticed, and unfortunately still always biting his cheeks and whatnot. It's awful. Obviously, I'm focused primarily in what I'm trying to do, spread the word about children, but is it ever too late to treat tongue tie in adults?
Now, it's always kind of more beneficial to treat patients that are growing, because once we have growth on our side, results are probably a bit more easy and we can make lasting change. When we treat adults, which I treat a lot of adults as well, we've got to understand that growth is kind of finished at that point, and we're having to deal with the consequences as well, which is usually, like you said, lack of tongue space, because that tongue's not been up there. So we usually have to treat them with orthodontic treatment first. We've got a lot of years of compensations to get rid of, because you've got to think of a child, they've been compensating for maybe about 10 years, which relatively in the whole lifespan of time is not very long. When you've got a 40-year-old adult, that adult has been compensating for 40 years, day in, day out. And you've got to undo all those habits as well. And at that point, then also we've got to look at changing the anatomy and changing the neurophysiology as well. So a lot of this, the process as well is a lot more involved. Personally speaking, I'm trying to raise awareness to get it identified in infancy under the age of 1, because at that point, let's put it this way, from a surgical point of view, a tongue tie release is only a few seconds. Okay, so if you use a laser, you can release a tongue tie, lip tie, and it's very quick and efficient. Parents are doing some exercises for about 4 to 6 weeks. They're seeing an osteopath. And if we look at it throughout the whole period of time, treatment time's like 4 to 6 weeks, which is, what is 4 to 6 weeks in the whole relevance of our life? Very, very, we'd end up the older patients, yes. We're looking at a few more months, but we get an adult, we're sometimes looking at years of treatment to kind of get them ready, plus treating the speech issues, dental issues on that side.
Okay, so we've delved into tongue tie. You mentioned lip tie there, and that's something that I actually suspect both of my, well, I know they've both got it, both of my sons, but it's not something I've even pursued any treatment on or looked into for now. I'm not aware of what the effects of lip tie are. I'm more aware of what tongue tie can do. Is it similar with lip tie? Is it the same sort of downstream effects, or can you go into a bit more detail about lip tie in particular?
Okay. So what I see in a lot of my patients is tongue and lip ties usually come in pairs. So in about 98% of patients that I've observed, I see a tongue tie and lip tie together. Now, the lip ties can be upper or lower lips, and what they usually do is they inhibit the lips from moving very freely. Now, when we look at upper lip ties, these effects can also be with speech. My own data is also showing that once we do lip tie releases, patients are finding a lot easier to breathe through their nose. And some patients even compared it to me like my nose was blocked and all of a sudden I'm breathing a lot better. And if it was one, I'd say, okay, this is just a random incident. This has been reproduced in the data that I'm collecting nearly in every patient. And actually, this credit goes to Dr. Baxter, who's the first person to kind of tell me to start looking at it. And I've been now trying to document this. We're going to hopefully get something published soon at some point about this going forward. Lip ties also, we're finding when I'm working with osteopaths and body workers, they are finding that sometimes it does affect the muscles of the neck. So this is usually when we do guided releases. I'll have the osteopath, the body worker with me as I'm performing a release, and they'll be feeling the body and kind of telling me which areas are still tight, etc. And sometimes they are saying that the tension's going up. There's one little point, and then once we release the lip or lower lip tie, that tension dissipates.
Wow. I mean, it's amazing how it's all interconnected. So release seems to be the way to deal with these things. To have the lip or the tongue released is the best option. So once a tongue tie or lip tie is diagnosed, what options do we have and what does that look like?
Depends on the age. Now, in the UK, there's very few of us who are laser trained. I think as far as I'm aware, there's only about 3 of us. Now, when we talk about releases of tongue ties, this is where I get a bit unpopular, and I'm very honest with people. My background's oral surgery. So I've used scissors, I've used scalpels, you name it, I've used that kind of instrument on soft tissues in the mouth. I don't feel that scalpel and scissors are a suitable option for babies because of the risks of the iatrogenic damage. That means damage from the actual procedure, because babies are a moving target. If they suddenly move, you can cut something you don't want to. So the tool I recommend is a CO2 laser, because it disinfects the area, number one, which is very good for toddlers and babies to avoid any kind of infection. Number two, as a surgeon, I can see what I'm releasing because it peels the skin away layer by layer and it allows me to stop at the actual endpoint. And studies even showing that laser treatments are very gentle on other structures such as nerves and blood vessels, because the biggest issue, like I said, when I first did a tongue tie release, was bleeding. And then once you switch over to a laser, that's almost negligible. It also allows us to treat lip ties with ease. And the biggest pro of all this is when I'm comparing it to my patients who I used to use wet instruments like scissors or scalpels, they were a lot more sore. We had more inflammation, more swelling. When I moved over to using a laser, that swelling was heavily reduced.
Unfortunately, when I took my son to have his tongue released, it was performed with scissors. And that resulted in an overnight stay in the hospital for him because there was excessive bleeding. And then in A&E, they applied tranexamic acid on it to stop the bleeding. But they left it on there for 4 hours and it created this secondary sort of issue where all these clots gathered in his mouth, and there was talk of him maybe having to have surgery and just all sorts of things. It sorted itself out in the end, thankfully. Any parents that are listening, I really want to second what you said there and just find someone that does it with a laser, because it really was a bad incident for my child. And he was 3 at the time, so he was old enough to really feel what was going on. We did have the same procedure with my younger son. He was 3 months at the time, but I suspect that it's reattached, which we're going to go into now, is the body work or the aftercare of a tongue release or a lip release that I've learned the hard way is just as important as the procedure itself in a lot of ways. So can you talk to me about what that looks like and why it is so important?
So the post-care, like you said, I agree is probably sometimes, if not even more important than the release itself. So a lot of times I see some other surgeons who are very good at doing cuts, which I'm going to say is fantastic cuts, but then they haven't done the correct aftercare, which something for babies is doing exercises at least 3 times a day and osteopathy. Now, the reason I get asked a lot is, what's the rationale behind this? Now, to make it very simple, when we release a tongue tie, we get a little diamond like this from a baby, okay? Now, the body will see 2 edges of the wound and want to close it up, okay? If, unfortunately, this is done with scissors, we've got a lot of blood in the area, and that blood clot is going to heal very, very quickly. And what we want to do is we want to avoid it growing together with tension or scar tissue that's going to restrict movement. Otherwise, our kind of initial procedure has been in vain. So we advise parents to gently elevate the tongue. Now, unfortunately, it's not the most comfortable thing to do because you're signaling to the brain the tongue needs to move, but you're also, in essence, doing micro tears to the wound. And the way I describe this to a lot of people to understand is, if you've ever fallen over and grazed your knee, okay, and you get that big scab there, if you don't move that knee, that scab is going to grow with very thick tissue, which is going to skin, which is going to be very inelastic, and you're going to have discomfort moving your knee in the future. However, if you're constantly moving your knee, you get small little micro tears in the scab, and that new skin will then grow in little bits and pieces. So the aftercare from the terms of wound care on that side is, you don't want that tongue to sit down in the mouth and be tight. You want to keep that mobility to where it is. Otherwise, let's put it this way, the procedure is almost done in vain. So if any practitioner doesn't advise you to move their tongue, and unfortunately the tongue is so sensitive and the mouth heals so fast, it needs to be a very specific set of exercises, either set to you in older children by a myofunctional therapist or a speech and language therapist with myofunctional training. And the body work in this sense basically stops those compensating muscles, the jaw, the back of the neck, from tightening up and then pulling the tongue back into another position. So the aim of both of these is to keep the mobility as good as it was from surgery.
You mentioned a myofunctional therapist there. I went to see one a few weeks ago, and one of the things that she mentioned is that they can offer pre-tongue release exercises as well to help before surgery. Is that something that you would recommend, sort of seeing a myofunctional therapist prior to going for a tongue release?
100%. Myofunctional therapy and in babies, body work prior makes a lot of difference. Now, when you've got an older child, myofunctional therapy first helps strengthen those neuronal connections between the brain and the tongue. So it helps your child kind of understand they can actually move their tongue, however limited it may be. And B, it helps strengthen the tongue. So that tongue is going to perform a lot better post-surgery than without. Now, this has also been shown in literature. So they did a randomized controlled trial of patients who had tongue release without myofunctional therapy and with. And patients who had treatment with myofunctional therapy had better post-operative results. So less scar tissue formation, less reattachment, and it also worked on the side, so less sore as well. Now, when you treat an older child, you do need to suture the area because suturing also helps us get a very thin wound, which is easier to stretch. But myofunctional therapy is a backbone in my practice as well, which is why we have our own myofunctional therapist. And those all my patients will see the myofunctional therapist sometimes before they see me as well. So the myofunctional therapist works as building tongue tone, and I don't do any releases if my patients are not being cleared by a therapist as well.
Oh, that's really interesting to know. So you really do work in that multidisciplinary way. That's amazing. Talking more about that, about working with other specialisms and all sort of working together for the greater good of the patient. My experience is that not one specialism can answer all these questions, especially when we're talking about airway health and mouth breathing as a whole. So am I right in assuming that a tongue release alone is not just going to be enough to answer these questions? Is it a case that we have to be accepting that we need a multidisciplinary team around us to assess all of these things and treat them?
100%. Now, I tell to a lot of dentists, I say, your patient's not just a floating set of teeth. It's not a floating mouth. It's not a floating tongue. That's connected to other organisms. And so actually, if you look at the General Dental Council's standards, it says we should be treating our patients holistically. And holistically means that we should be identifying a lot of other issues. Now, in practice, this is very limited because sometimes people are limited with time, etc. But multidisciplinary care makes the world of difference to your patients. Seeing someone who can then say to you, okay, I can treat your tongue tied, but I think you need to see a myofunctional therapist for this. I think you need to go see an ENT surgeon to make sure your nose is breathing well. I think you need to see an osteopath to make sure the tension's gone. And I think you need to see a gastroenterologist to help with the digestion or swallowing side. It is so vital that we all work together in one team. That's why I tried to get everyone in one place so that patients can come and see me. And I know that, okay, I can send them next door to see the osteopath. I've got my pediatrician with me. She does tongue tie releases as well. And she can also help them with their general health as well on that side, make sure that health is optimized. If we start promoting this team approach, I'm hoping the NHS will start taking more notice of us and then start implementing that, because it's really sad to see that someone only looks at one thing. Like one dentist will only look at one tooth, the ENT, a doctor will only look at one part, and then no one's kind of gelling everyone together, which is what we should be doing. In terms of patient care, it increases patient satisfaction, treatment outcomes, because you're all working together for the same goal, which is to help your patients. And also orthodontic care, which I completely forgot because I have an orthodontist as well with me. Correct the tongue, but there's no space for it. I'm at an endpoint. Yeah, we could get good tongue mobility, but if I can't talk to Dr. Biju, my orthodontist, and say, Biju, we need to get the space increased, or sometimes it's a question that he's seeing the patients first and getting some more space before I even do my release. It makes the world of difference for patients, because in the end of the day, egos all aside, the most important thing to us is, are our patients thriving and are they getting the best care possible? And sometimes it's all the question of, they see one of us, we take a full history, and we have a discussion together as a group to kind of think, okay, what's going to be the best way forward?
Yeah, I mean, my next question for you was going to be about the NHS and how we can improve that system. I know it's a bit of an impossible question in a lot of ways. Budget and all of those things affect it. But my experience certainly has been that it's very disjointed. Nobody is talking to my son's got a hearing aid to help with glue at the moment whilst he's on the waiting list for grommets. But that team doesn't talk to the ENT team. They are now, because I've specifically requested that, they push for surgery a bit sooner for him. But I've definitely seen that all of these people are speaking different languages. They've got their own biases. And there isn't just that general sense of, right, we're working together for the greater good of the patient. And I think it is, more of an issue within the structure of how the NHS work, unfortunately. But one of the, I'll go through it in a minute as we sort of wrap up some of the questions that people have sent me for you. But one of them is around feeding, and how feeding in young infants is usually how parents discover that their child has tongue tie. But even through my experience of, I mentioned earlier on, 3 months of my young child struggling to latch, I had a lot of nipple trauma. Now you've mentioned about the excessive air that can get taken in with a tongue. I didn't know that at the time, but that really makes sense to his particular case. It was a horrendous experience. And I went to the midwife, I went to the GP, the health visitor, and nobody, not one person, mentioned tongue tie to me. And when I say I was up, I'm very passionate about breastfeeding. I did it with my first, actually didn't have any issues. I was up in the night sobbing, trying to get my son to latch. He was having so much discomfort. I was in pain. It was just awful. So what do each of these professionals need to know about tongue tie and its wider implications? So I'm talking about, the midwives, the GPs, the health visitors. What do they need to understand?
Well, firstly, I'm really sorry you had to go through this whole deal, and it must have been really hard for you. And once again, you've done so well to work through it and be where you are now. If I was to tell everyone what kind of the GPs, etc., I would know is we all kind of train to look at symptoms. And the good thing about that is symptoms kind of leave patterns and kind of little breadcrumbs around for us to look at. Now, when we come to the UK, we're very kind of symptom-based approach to treatment. Okay. And sometimes that's good because you only treat when you've got symptoms. But a lot of the time, if we look at the Americans, they're very proactive. So what I kind of was telling a lot of health visitors and GPs are saying, look at listen to your parents, your patients, number one. Have a look at your child. Are they feeding every 15 to 20 minutes? Because if they are, something's going on. Imagine as an adult, you're eating every 15 minutes. That's not healthy. Ask them about sleep. Say, how's your child sleeping? Oh, they're horrendous. Oh, they're waking up all throughout the night. Oh, they're mouth breathing. They're snoring. You can pick up snoring in a baby from a very young age, because snoring in babies is so uncommon. It shouldn't be there. Baby sleep should be near enough quiet and very silent. You should hear them breathing, but the mouth should be closed. And you should gently open the mouth and the tongue should be out. That's healthy sleep in an infant. And that's what I tell a lot of GPs as well, is ask your patients how they're sleeping. Ask the mothers, like, how's breastfeeding going? Or is there any reason why it's not doing well? And what I tell mothers, and I try and empower them, is listen to your mother's instincts. Understand that common is not normal. Okay? Mother's instincts, if we didn't have them, we wouldn't be here as a species. Let's just put that out there. A lot of times you've been told things are common, like you must have been told in your case, oh, you've got bleeding nipples or mastitis, that's common. Here's what we can do for you. But what we must also understand is, okay, while it's common, what's the cause? And this is where I tell healthcare professionals, think about your patient who's coming to see you and ask, why is this happening right now? What can we do on that side?
Okay, that's really, really helpful. I feel like there are so many gaps and there's just not enough information even for these specialists. I mean, a GP has spent however many years studying, but it comes to what is fundamental to keeping the human species alive, feeding your own child. And I was sent away and told that it was colic. Now I know that colic is a bit of a BS term, excuse my French, but it is, it's just something to mask over. And it's really frustrating. And one of the reasons why I've sort of tried to start this movement is as a way to channel my anger. And, I have a lot of anger with having to go through all of these things. And when you're so desperate to, nourish your child and there are all these issues and everyone's suffering, and to be sent away feeling like you're a bit nuts because it's normal and everybody goes through this. And actually, it's not. And as you say, it might be common, but it's not normal, and that doesn't make it right. So I've got a couple of follow-up questions to end on. Some we might have covered already to some degree, but does everyone with a tongue tie need it treated?
Very good question. Now, what I would say to most of my patients is it's better we identify it. Then I like to give this decision to the parents. Now, what that means is let's say you came to see me with your child, we have a chat and you're saying, well, breastfeeding is fine. He's sleeping with his mouth closed. Everything else is all going fine. And I'll say to you, well, we have a grade 4 or anterior tongue tie here, which is at the moment, he's compensating well. Now, the question is, when it's children, the parents have to make the decision is it appropriate or not? Because I will be there to guide you about the future at that point. I'll say, in the future, we may see poor issues with the mouth, poor issues with the swallowing, poor issues with speech in the future. Then my job is to guide you as the parents to say, okay, treating at this point is very efficient. Treating later might be a bit trickier. If there's no symptoms at the time, I don't think treatment's urgent, but I think it's better we're aware and we have the chat of, okay, do we act more proactively or act more retroactively or symptomatically in the future?
The next question actually is, what is the difference between anterior and posterior tongue tie?
So anterior implies it's the front of the tongue, or these are what we call the more, like what the untrained tongue tie practitioner will call the more severe tongue restriction. Posterior are the less obvious ones. So posterior, which we now switch to middle of the tongue restrictions, are more towards the middle blade of the tongue. And that's where sometimes we see more issues with the swallowing, etc. So for anyone who kind of wants to understand this, anterior is obvious, posterior is less obvious.
Okay, but both. Okay. Somebody asked me why the conversation around tongue ties becomes so much more prominent in recent years. And another person gave me a statement to say they think tongue tie is a little bit of a fad. So can you just give a bit of an insight as to why it's become more prominent?
Okay, so here's what I kind of feel personally, and this is all anecdotal and based on my observations of history, trends and data, etc. Now, before the Second World War, bottles were not very widely available, and infant mortality rate was quite high. Now, we didn't have the kind of insight to look back, but we saw an old surgical textbook, I think from 1940, which basically discusses tongue tie treatments and says that with the introduction of bottles, this treatment is no longer needed as infants then now can feed really well. And if we look even further back in history, we used to have midwives using their little finger with a sharp nail and kind of doing a swipe underneath the patient's tongues to make sure there wasn't any restrictions, because they kind of found out that that would impact feeding. We then kind of went into this whole dark age where if a child wasn't breastfeeding, you give them a bottle and it's all done. And then in recent years, we kind of wanted to increase our breastfeeding rates because we understand breastfeeding is very beneficial for the development of the mouth, face, getting nutrients on that side, helping mothers and babies' oxytocin levels, and most importantly, leading to better nourished babies. And then we started to see more issues with feeding. Now, if someone asked me, is tongue tie a fad or is it a fallacy? I kind of tell them, all right, why don't you walk around with both your feet tied up and tell me how you operate your life? Or even better, have all of your whole hand whipped and try and have a drink and grip something. Yeah, you might be able to do it. It's going to cause you, make you have a lot of energy. You're going to basically be frustrated a lot. And to top it off, let's give you only 2 hours of sleep every night, regardless of whatever you've gone through. You then tell me, is that going to be a happy, functioning person? Is that going to be an efficient organism there? What we kind of get, and I'll leave that to you all.
Well, that sounds like a really good place to wrap this up. So yeah, thank you so much. I really enjoyed this. It was very insightful for me and very, very helpful. And I'm sure it will be for the parents as well. So where can people find you if they want to follow your work or get in touch with you?
Well, thank you again, Natasha, for having me. If anyone wants to find me, I'm at Happy Kids Dental, the tongue tie and breathing center. So you just go on www.happykidsdental.co.uk. If you want to get in touch with me directly, it's my Instagram page is at Dr. S. Vatish DDS.
Awesome. Thank you ever so much. I'll pop all that in the show notes as well.
All right. Thank you very much for having me.
Thank you.
Okay.
Bye-bye.
Bye.
Bye.